So why don't we move on to the next topic today, and we can talk about biceps tendon. So you're all familiar with the biceps tendon, so I don't think we need to go to the anatomy. It has a primary insertion right superior to the labrum, and it may or may not have a mechanical connection to the superior labrum, and then it also has these other little rootlets going off both sides. People could silence. We're getting feedback, so maybe if people who aren't talking silence their computers. Thank you. And then you can see it in multiple planes on an MR scan. There are some people in the early days that try to do oblique planes, but that turns out to be quite difficult, time-consuming, and it doesn't really add a lot. So typically, we look at it on the coronal and sagittal planes. And here we can see, here's the superior labrum. Often you can see a separation between the long head of the biceps insertion and the superior labrum. Many times you can't. This is the insertion of the biceps, the so-called biceps anchor. If we go one cut more anteriorly here, we can start seeing the separation between the superior labrum and the biceps anchor. This is one of those little rootlets off to the anterior insertional portion of the long head of the biceps. This is the long head of the biceps coming around here. If possible, I like to scan the shoulder in external rotation, and then we're more likely to get the biceps in a single plane in the coronal plane. But a lot of people who have shoulder pathology have a lot of pain in the external the rotated position, and therefore you have to image them in neutral or internal rotation. So that's a biceps tendon in the coronal plane. The sagittal plane, this is the insertion of the biceps here on the superior portion of the glenoid. If we go one cut out, the biceps insertion and the coracohumeral ligament are really kind of together here. And then if we go further out, we can follow the biceps tendon over the humeral head until it finally ends up down in the intertuberous groove. In the axial plane, in the intertuberous groove, we can see the lesser tuberosity, the greater tuberosity, the biceps tendon in between the two. It should be nice and round and black in this location. And you can follow it up, but typically when you follow it up, you start partial voluming it, and it's difficult. But in the intertuberous groove and distally, we can see it nicely in the axial plane. So here's a case, Pablo. What do you think of this case?
Okay, so we have an axial view, and I don't see the biceps tendon there. Okay. There is some high point.
You really don't see much over here where the bicep should be.
Where it should be. Yes, looks like it's.
Right here. And then if we go up from here, this is what it looks like.
Okay, so this is a more superior and.
Here we're getting into the level of the joint space.
So here I'm not sure if the biceps is flat by the subscapular tendon insertion there closer, but or it's just the cortex of the.
Where's the intertuberous groove?
Actually, yeah, it's very shallow. Well, there's none. Yeah, it's. It looks like it's probably a congenital then, and maybe the tendon is dislocated, chronically dislocated.
And we don't see any tendon in through here. Mm-hmm. And this is congenital absence of the long head of the biceps.
Oh, it's absence.
Pretty uncommon, okay. But when you have a congenital absence, then you don't develop the intertuberous groove, and you just don't have a.
If you look at the subscapularis and its insertion, you don't see a groove there. It's kind of a flat area, and so that kind of gives you an idea that the biceps was never there.
Yeah. Okay. Here we go. What's going on here?
27-year-old female professional volleyball player with shoulder pain. And it looks like there are two round hypointense structures in the intertubercular groove. So it could be a Bifid long head biceps tendon.
So what are these things called?
Those are the peritenons, or
they're called the vincula.
The vincula.
And You can't always see the vincula, but a normal bicep should have one biceps tendon and a vincula. So the way you differentiate a congenital bifid biceps from a longitudinal split tear is one, the signal intensity. The other is that the congenital bifid, you have round tendons, whereas if you have a tear, it's usually irregular in between the two. And if you have a congenital bifid, you have vincula going to both components, whereas if it's a tear, you don't. So this is a congenitally bifid biceps tendon.
43-year-old shoulder pain. So, whoops. So I'm not sure I'm seeing the biceps long head. If that thing we're seeing, that elongated structure in the joint, then it's dislocated. If that's the biceps long head.
Are you talking about this or that?
That, but I guess
This.
yeah. It might also be that it's just. Let me see for a second. I don't know. I'm not sure I'm seeing it. Yeah.
So if this were the biceps, what's this over here?
I think it could be another tendon, possibly, or a ligament.
So what we have here is a disco biceps tendon into the joint space. We'll talk about how that occurs later. But since the biceps over here is what this shows is very nicely what's called the accessory head of the biceps brachii. And it comes up from the biceps, but it inserts on the humerus and doesn't go all the way up and insert on the glenoid. So, and you'll if you look for it, you'll see it fairly frequently as kind of a thickening on what looks like at the transverse ligament of the in the intertuberous groove. In this case, that's the accessory head of the biceps, and the main biceps or the long head of the biceps is dislocated into the joint space.
Was the long head of the biceps dislocated congenitally or
No.
chronically? No, it just happened.
No, trauma.
Trauma, I see.
Yeah, and then you know it varies a lot. It's less common in Asians, more common in whites, and so forth. So this is just the accessory head coming up here to insert on the humerus, and the long head of the biceps goes over and inserts on the glenoid. Okay, and this is just some histology showing the two. And there's the accessory, and there's the long head of the biceps. Okay, let me see who all we have here today.
John, have you done a study on how often you see this?
No, I haven't. It's as you see it in whites is pretty common. It's about a quarter of people in the whites where you can see it.
Okay.
Yeah. Sahara, what do you think of this case?
Okay, right shoulder pain after a fall 2 months ago. Seems that the long head of the biceps is medially dislocated on the second image. And
There's an axial.
okay, so on the axial, okay, I see two structures running here.
Okay. See
One,
this structure and this structure.
right.
Okay.
So this is an accessory biceps running medial.
Well, it comes up here. Okay. So, right. So it's an accessory biceps, but where's this one running to?
So this is running anterior.
So this is a little bit confusing because we have a completely torn subscapine retraction, but this would be the normal biceps, and this is actually an accessory biceps, but it's an accessory to the short head, which normally, where does the short head normally insert?
Goes to the coracoid.
Coracoid, and And this is an accessory short head, which actually goes to the glenoid. So, see that? Oh, you see it right there. No, well, you can see it's inserting right here. It's inserting right here in the anterior superior part. It really goes up right up to here. It is high. See, you can see it's going all the way up here.
Why not call that the regular long head? It seems
but because the regular long head's in normal position. Whoops.
So that other one also
and it also comes from the short head muscle. It doesn't come from the long. Okay. Yeah. So you can have accessories of the long tendon, which are common. Accessories of the short tendon are much less common. Okay. All right. Thomas, what do you think? What's that structure that the arrow is pointing to?
Right. So there's two low signal intensity structures in the bicipital groove, and like we said earlier, if it's a bifid, we should be able to see the vincula, which I don't see.
If we can. And this one is also really around the area of the intertuberous groove. So this looks more like an accessory. And this is a thickening of the aponeurotic expression, which is a type of accessory long head of the biceps. There's a lot of terminology here. I won't go through all this, but it's really thickening of the transverse ligament right in through here. And they're different types. But they can be a little bit confusing, but they all really look like maybe an accessory biceps. So the bottom line is they're not significant. So if you see it, just don't be confused by it.
They are part of the supraspinatus, or is it an extension of the supraspinatus?
Well, the transverse ligament is really an extension of the subscapularis. But it's just thickening of the transverse ligament there, right? Okay.
40-year-old female with right shoulder pain for 3 weeks, night crying, pain. See, so we have a coronal view. Looks like there's thickening of a structure there that could be the biceps tendon, or maybe the supraspinatus. Yeah, it's more posterior. And traction, yeah, cystic of the greater tuberosity. Okay, here, so looks like the arrows are pointing to the biceps tendon insertion. And let's see, it's going at
dark thing here which attaches to the glenoid, and another one.
Yes.
And there they are right there. And this turned out in surgery to be a split long head of the biceps tendon, which is split kind of horizontally, and the superior portion was adhesed to the long head of the biceps, but it's still attached here. So this is a longitudinal split tear of the biceps. I've never called one that's adhesed to the supraspinatus, but this was a surgically proven one. And some of these may be congenital, so we don't need to go through all the different types that have been described. Okay. What do you think here?
So it looks like I see some hyperintense signal and some irregularity of the normal ovoid shape of the long head biceps tendon. So I'd be considering partial thickness tear, some tendinosis.
Here. This is the sagittal.
Yeah, there I don't really see it intra-articularly. Or, okay, there it is.
This is it coming along here, and then we get this longitudinal increased signal intensity within it coming into the intertuberous groove, which will be the next cut right out here.
Looks like a split tear.
Yeah, so it's a more typical appearance of a longitudinal split tear of the biceps, and these tend to be symptomatic.
Oh, there's a lot of increased signal in the intra-articular portion of the biceps long-headed tendon here. It's at least tendinotic, maybe some. It's kind of perched, and I mean, there's probably some intrasubstance tearing, but the fibers are in continuity anyway.
Certainly have a lot of intra-articular signal within it here. You don't see a black structure at all. And this is intra-articular biceps tendinosis, like we talked about and all the other tendons up till now. And you've all seen this in reading out cases, very common finding. Okay. Now, we need to talk a little bit about the bicep sling anatomy. So we have the short head of the biceps tendon that goes to the coracoid process. The long head goes up through the intertuberous groove, where it's held in place by the transverse ligament here, which is kind of extension fibers of the subscap that goes over toward the supraspinatus. We also have the coracohumeral ligament up above that you've all seen that kind of help hold it into case. And this just shows the biceps tendon, and that's that transverse ligament that you see on MR examinations. That's what it looks like right there. And then the coracohumeral ligament goes over it in this area as well, right over this area. This is the biceps tendon. This is where that coracohumeral ligament goes over as kind of a broad band of fibrous tissue, which helps hold the biceps tendon in place. And then there's a superior glenohumeral ligament, which attaches just anterior and a little bit inferior to the long head of the biceps insertion. Then it comes up anteriorly, kind of wraps around the anterior part of the tendon, and then attaches out in this area to the humerus. And that wraps underneath the long head of the biceps tendon, and it helps hold the biceps tendon in place so that it doesn't sublux anteriorly. And this is the sling mechanism that the surgeons talk about.
Is that superior glenohumeral ligament surrounding the biceps completely?
No, it's just coming out. It's just right here. It attaches anterior and a little bit inferior to the long head of the biceps. It comes up in front of it and then wraps around it to keep it from inferiorly and anteriorly displacing. So this would be the superior glenohumeral ligament in that location. There's the biceps tendon insertion. Here's the superior glenohumeral ligament coming out anterior. And this is another example. This is before you remove a lot of the structures. If you look in the sagittal plane, this would be the superior glenohumeral ligament. It comes anterior to the biceps and then comes under it and then attaches, so that if the biceps goes forward, it basically is stopped by the superior glenohumeral ligament. And when this is torn, it's often torn when you get subluxation of the long head of the biceps tendon and allows that. And this is here, you can see the tendon, and the superior glenohumeral ligament wraps around underneath it to help support it up and to keep it from going anteriorly. So the coracohumeral ligament there. And then here on the MR examination, this is the intraarticular portion of the biceps tendon. Here's a coracohumeral ligament, which helps stabilize it from above. And then if we go a little bit, okay, and then this is just another example showing the same thing. Long head of the biceps tendon, anterior to that is superior glenohumeral ligament. And if you see here, the superior glenohumeral ligament starts out anteriorly, then it flattens and comes underneath it here to stabilize the ligament. So here's another example. So here's the biceps insertion. Here's the superior labrum. Biceps anchor is right there. Go to the next cut. Here we're seeing the biceps tendon, coracohumeral ligament there, and this is a superior glenohumeral ligament coming here, and they're kind of stabilizing it, holding it into place. Go to the next cut over, and here now we're past the insertion of the superior glenohumeral ligament, and there's the biceps tendon getting close to going into the intertuberous groove. Again, the coracohumeral ligament above it. And now we're following it as it goes into the intertuberous groove here and extends distally. Here's just another example where we can see the superior glenohumeral ligament, the coracohumeral ligament, and this is the sling structure that stabilizes the long head of the biceps tendon. And here we have a superior glenohumeral ligament tear where we don't have that, and that's the coracohumeral ligament. The superior glenohumeral ligament is torn, and the biceps now is subluxed inferiorly and anteriorly, and it's not held into place anymore. And here we can see it's too anterior here. And on the So this is kind of either the supraglenohumeral ligament can tear and it can go forward. Often that's associated with a tear of the superior fibers of the inferior glenohumeral ligament. So this would be the superior glenohumeral ligament tear, or you can have the superior glenohumeral ligaments down here, the coracohumeral ligaments up there. Here, the coracohumeral ligament is torn, and the biceps is going anteriorly. But more commonly, you can get this tear of the superior glenohumeral ligament, and the biceps would then dislocate anteriorly and inferiorly. Now, in looking at biceps instability, you've seen this before. This is modified from Bennett et al. In arthroscopy in 2003 of the different grading systems for looking at instability. And a bunch of these I've kind of added that are in the radiology literature, the more extensive ones. So we'll go through these. A lot of the surgeons around here prefer to use a grading system from Habermeyer, which was published the following year. And here, a type 1 is a superior glenohumeral ligament tear with a perched biceps. A type 2 is a superior glenohumeral ligament tear with a tear of the supraspinatus tendon. A type 3 is a superior glenohumeral ligament tear with a subscapularis tear. And the 4 is a tear of everything. And here, typically, notice that the common thing here is all of these that have an unstable biceps, the superior glenohumeral ligament is torn. So we can get perched, and then the question is it a tear of the anterior supraspinatus or the subscapularis? In my experience, most injuries where you actually get dislocation of the biceps tendon, it's really subscapularis tear that allows it to sublux. Yes.
John?
Yes.
Doesn't it depend on how the arm is positioned as to how much perching you get or dislocation of the biceps?
Yes, you can certainly affect it. If you put tension on it, you can increase the prominence of subluxation. That's right.
One thing I also wanted to say, one thing about the biceps tendon, the long head, is even if it's normal, if you palpate that area, you can find it because it's a bit tender in even normal shoulders.
Yeah.
It's a very sensitive tendon.
Yeah, it's a fairly common cause of anterior shoulder pain, and we'll talk about that in a minute.
In normal biceps.
Right, it's tender, right.
I'm sorry if I missed this. Did you explain how supraspinatus tendon tear contributes to biceps instability? I didn't catch that.
So this is the Habermeyer classification in this particular paper. This would be the normal. So you have the biceps tendon here, the superior glenohumeral ligament, the coracohumeral ligament, supraspinatus, and the subscapularis. So if you could have a tear up in this area, in this particular case, a type 1 would be a superior glenohumeral ligament tear. I don't really like this diagram all this much because I think they occur at a slightly different location. You can have a group 2 where you have a superior glenohumeral. I'm sorry, this is in the axial plane. Excuse me. This is the supra and this is the subscapularis. So this is a right shoulder. So this would be normal. This would be a type 1 where you have a tear of the superior glenohumeral ligament and you can get a little bit of perching of the long head of the biceps tendon anteriorly here. A type 2 would be where you get a tear here at the base of the supraspinatus tendon, which then causes a laxity of this whole mechanism, and you'll get a little bit of anterior perching of the biceps tendon. And in my experience, tears in this location of the supraspinatus tendon, as detected by MR, don't tend to be highly associated with biceps instability. Because as you know, these are the most common tears that we see, and most of the time the biceps is normal with these. So, but this is in the surgical and subsequently the radiologic literature. So this would be a type 2. not one that I find very common. Type 3 is where you have a tear of the subscapularis and subluxation of the biceps into that, along with the tear of the superior glenohumeral ligament. And the type 4 is with both. So a lot of surgeons use this classification. Personally, from an MR standpoint, it really looks like the action is really in this location. And I personally would use a different grading system from this based upon what I see. What it doesn't include here is the fact you can get a tear of the transverse ligament here, and you can get a biceps tendon sublux anteriorly to the subscapularis, which is about 15 to 20% of dislocations of the biceps, which really aren't included in the Habermeyer classification. They are in the Bennett.
For that, you need an injury of the coracohumeral ligament? Or
yes,
to go
a coracohumeral or a distal tear of the subscapularis. But generally, it's the coracohumeral ligament as well as the superior glenohumeral ligament. So I'm going to talk about the classification I kind of like here in a minute. So here's a case where we can see a lot of motion artifact. I should get a better one here. There's the biceps tendon. It's a little bit flattened, a little tiny bit perched, not much, but we can see a tear here of the deep fibers of the subscapularis. The transverse ligament may be a little bit tendinotic, but it looks like it's grossly intact. There's a partial tear of the subscapularis, minimally displaced biceps. Here's this same patient. We can see on the sagittal side, here's the elongated biceps tendon. Here's the coracohumeral ligament. This is the superior glenohumeral ligament, which is abnormal here. This is a torn superior glenohumeral ligament with minimal perching. So this would be basically a Habermeyer 1, maybe 3, 1 to 3. But this is one that I would, in the Bennett classification, would be a grade 0. You don't really have subluxation, but we have a tear of the superior glenohumeral ligament. Habermeyer, maybe a 3. Okay, let's see, who's next? Who was last? Here, Sam, I think you're next.
Sam.
What do you think of this?
Radiologist, huh? Well, the tendon looks irregular. I think fragmented, probably torn.
There's the tendon right here.
Oh, is that the tendon? Oh, okay. So it's kind of perched, I guess.
Maybe actually it's almost normal. Maybe it's not quite.
Okay,
these 42803.
Oh, that's weird.
A few years later, when he came in now with anterior pain,
so
after doing push-ups.
Oh, okay. So first of all, on the earlier image, I mean, now that you're telling me where the tendon is, I would think that the superior glenohumeral ligament is actually maybe torn, but
you can't really see the superior glenohumeral ligament here. We're
under
too inferior.
Where it's inferior. Okay. So here.
The glenohumeral ligament is up here, higher up by the
Yeah.
top.
Okay. Well, in the later image, it looks like slight delamination of the subscap, and the biceps elongate tendon is more perched now, starting to.
It's much more flat. And he was very symptomatic at this stage. Now, in the old days, or earlier days, this was called the hidden lesion, because you can't see this arthroscopically, and you can't see it by arthrography either. So this was a difficult diagnosis to make in the pre-MR days, hence it was called the hidden lesion. But it's a relatively common cause of anterior shoulder pain. If you blow that up, you can actually see this is more basically normal. And here we can see the perching, the flattening, and the partial tear of the subscapularis in this particular patient. Okay, and this in the Bennett modified Bennett classification, this would be a type 1.
What is it about radiologist behavior that, or is it just he happens to be a radiologist?
Yep, you happen to be a radiologist.
There's no like movement that causes.
Just let you know this can happen to you. So, okay. Okay, Sahar, what do you think of this case?
Yeah, we have single axial view of the shoulder, and it seems that the biceps tendon is perched. I think there might be a longitudinal tear also in the biceps tendon.
So
and
there's actually also a little bit of widening of the intertuberous groove. suggest that there's been a chronic problem here, biceps tendon, and then here, as you see, we have a partial tear of the subscap here, but the transverse ligament is still intact. And this is another grade 1 perched biceps. Now, historically, we used a grading system, this grading system, before Bennett actually published his paper. We used it back in the late 1980s, early 1990s, and then Bennett published his paper in 2003. But these are the sorts of things that we can see on an MR examination, and these weren't really described until MR came around, mostly in articles later in the 1990s. Okay, and then here's a 56-year-old male with acute worsening of chronic anterior shoulder pain. Thomas, what do you think of this?
Yes, we have an axial view of the shoulder, and looks like the biceps tendon is, I guess, subluxing into the...
Okay, so he had a chronically subluxed biceps. This is the intertuberous groove, and we can see that there's remodeling of the bone here, probably due to the biceps subluxation. And again, we have a partial tear of the subscapularis tendon in this particular patient. And here we have fluid in the subacromial subdeltoid bursa. This is an arthrogram. This is contrast, and that's fluid in the subacromial subdeltoid bursa. And this patient this is a chronic grade 1 subluxation of the biceps tendon. Okay. All right. The next thing. Here we go.
So I have an axial view here. I think I see the biceps tendon that is perched, and there's a tear of the subscapularis tendon. The tendon looks like it's the biceps tendon. It's within the subscapularis tendon tear. There is another hypointensity anterior to the glenoid. Is that just the one? That's the middle glenoid. Okay.
Yeah. So the other thing that we put in our classification as a grade 2 would be where you have subluxation of the biceps tendon, but it subluxes into the subscapularis tendon in this case. This is actually not commonly seen. To my knowledge, the first time we saw it was on MR examinations. I'm sure somebody described it before, but we couldn't find that. And we started seeing these in the late 80s and early 1990s when we first started doing MR scan. And if you follow these, they very rapidly will end up to a grade 3 that we'll come to in a minute. These are typically very symptomatic because these are actually in the act of actively tearing the subscapularis tendon as the biceps is pulled medially into the joint space by pull from the biceps muscle. So again, this would be another Habermeyer 3, but in our grading system, we like to give this a grade 2 because it's actually dislocated into the subscapularis tendon. Okay. Okay.
Do you put this in a report, Sean?
I describe it in the report saying that it's I don't put the grading system in the report. I like to describe the findings, and the grading system was just when we tried to do papers. Again, there's so many different grading systems out there, so unless you know the person you're talking to, you're using the same grading system, it can be very confusing.
I don't like any of them.
Yeah. So I'd like to describe it, but it gives it lets you see what the different kinds of pathology are so that you know what to look for to describe it.
Yeah, they drive me nuts.
I thought all radiologists drove you nuts, John.
All right, low field technique. And
no, radiologists are good folks.
It looks like
Thank you.
It looks like there's a complete tear of the subscapularis tendon with medial dislocation of the long head biceps tendon.
Yeah, this is a little bit out of order, but that's right. So now we have a dislocation of the biceps, very tendinotic, into the joint space. Yeah, I think it's torn here, but there are probably some fibers that may still be in it. The type 3 really is when you don't see a complete tear of the subscapularis and it's not retracted. And let me see, here's another example. These are very old scans. This is back when we were first doing our grading system. And you can see that the subscap still has some fibers intact. Anyway, so the question back in 1989 and 1990, we're asking ourselves, well, if the biceps tendon is supposed to be here, and it ends up here, and you've got the subscap in between that's intact, how does it get from there to there? And the answer is that what happens is that it's the pulp subluxes along the cortex, and it dissects between the superficial fibers of the subscapularis that go into the transverse ligament, comes down along the bone, and it cuts itself through the deep fibers of the subscap, and often the superficial fibers to the transverse ligament stay intact, so you don't get a complete tear of the subscapularis and you don't get retraction. You just end up having the biceps cut itself through the deep fibers. And I think that's what happens in these. So this would be our grade 3, where you don't have a complete tear of the subscapularis, but the biceps tendon has ended up in the joint space. And this is pretty common. This is much more common than the grade 2, where you catch it in the act of being in the middle of the two.
So those deep fibers, those are actually not inserting into the vessel tuberosity.
These right in here?
The subscap, the black line.
This is superficial fibers.
So they're not actually inserted into
these are, I think originally, initially they're just part of the transverse ligament, but eventually this can heal back again. If it does not pull back, the fibers, some of the fibers can adhere back to the bone again. Yeah, just like you have if you do a supraspinatus tendon tear where you use suture anchors, the tendons, you want the tendon to biologically heal back to the bone again. You just want to hold it in place long enough for that to occur.
Well, if you look at the left image, and that's the anatomy of this area, is the subscapularis goes all across, entirely across the bicipital groove. So what that biceps does is just slides underneath the subscapularis.
Yeah, but you can see why this can cause anterior shoulder pain. Good.
Oh, well, normal. What I'm talking about is a normal shoulder.
Normal, right. Yep, that's right. Okay, let's see. Who's next? Sam?
So here it looks like the deep fibers of the subscap are intact. This is subluxed at least. The biceps line is at least subluxed into what I guess is partial tearing of the subscap. And
I think the subscap's completely intact here.
Oh, so then it's just a transverse ligament tear.
The transverse ligament is torn, and now we have an extra-articular dislocation of the biceps. And when we were first looking at this happened about 15 to 20% of the time. 80% of the time, it ended up in the joint, and only about 10 to 20% of the time did the biceps tendon end up superficial to the subscapularis. So we call this a grade 4. Okay, and here's an example. We have a lot of tendinopathy of the subscap, but again, the biceps is dislocated superficial to the subscap in this particular case as well. So that would be our type 4. And we already talked about this one. I don't know why I have that here. Whoa. And then when you have a congenital bifid, you can get some kind of complex things occurring here. So here we're starting with kind of a type 4 in one of the bifid components, and the other one is still in place. And then here you can see that one of the components is dislocated superficial to the subscapularis here. In this case, we have 2 because this was a congenital bifid with pathology. So you can get complex combinations of everything. Okay, Sahar, what do you think of this case?
Okay, we have dislocation of the biceps tendon, and it seems that we have tear of the transverse ligament. Yeah. The subscap doesn't look good too. It looks torn here.
Here we have a complete subscap. This we would call it type 5, and this would be. If you also had a tear, the anterior insertion of the supraspinatus, which I guess this patient had, you would call this a Habermeyer 4. But, okay. Thomas, what do you think of this case?
81-year-old female injured throwing a ball, and it looks like there's intra-articular dislocation of the biceps tendon, and subscap also looks torn.
Yeah, so this is another type 5, our type 5. Good. All right.
Have a 28-year-old male with shoulder pain after a motorcycle accident. Have an axial view. See the biceps there with a lot of fluid around it.
Here's the next cut.
Okay, so it's extending laterally. And okay, it looks like there's a dislocation of the glenohumeral joint anteriorly, and it looks like the biceps is dislocated posteriorly. It's
so this is a posterior dislocation, which I had never heard of until Rick Arrigo showed this to me. So this is a posterior dislocation. There are only about 3 or 4 in the published literature, and so we call this a grade 6, since we're up to 5, and this one we've found, so we gave this a 6, and that's from Rick, and that was actually a good reason not to ride motorcycles. Okay. And then here we can see in this low field study, there's no biceps tendon, it's torn and distally retracted, and so we just consider that a type 7, a complete biceps rupture. Okay. And then here's a bicep. Here we can see there's no tendon in the intertuberous groove. And here we can see it's distally retracted, and then there's a big hematoma here on this low field study. And then here's a case where we don't see a biceps in the intertuberous groove. When we come up into the joint space, we can actually see that the biceps anchor is still here. So usually when you have a rupture of the biceps, it's at the biceps anchor, but you can have a tear more distally, in which case you end up with a stub of biceps here. And that's important to note, because sometimes this is another patient, these stubs can hypertrophy and actually act as a loose fragment in the joint space. So if these get there and you start getting symptoms where they start impinging, they may have to be removed. That's very uncommon. The vast majority of biceps ruptures are at the anchor, but if it's a more distal rupture and you got kind of a big thickened stub that's left there, you need to describe that in your reports, because that may change the way in which the patient is managed. Sahar, what do you think of this case?
A 53-year-old female with pain and decreased range of motion. So it seems that we have like moderate grade articular surface tear of the supraspinatus in the first image. Yeah. And the bicipital groove is kind of empty. I don't know, we have like partial tear of the biceps. Okay, and it's dislocated too. Biceps is dislocated.
So this is basically a biceps tear with retraction. You just have a little bit of a few little strands of biceps which are extending distally into the intertuberous groove. Okay. Alrighty. Thomas, what do you think of this case?
So I have a sagittal view, and I think I'm seeing the discontinuity of the biceps tendon.
Well, this is part of the biceps tendon right here. This is the cortical humeral ligament. We don't really see the superior glenohumeral ligament very well here. And what's happened to the fat? This is the top of the subscapularis tendon, and we should have fat in through here.
Right, it's effaced, so I guess that could happen with adhesive capsulitis.
Yeah. So this is a rotator cuff interval scar, and one of the reasons why you may get pain from this is that the scar can attach to the biceps tendon, and whenever you tug on the tendon, it can produce pain in this area. So right. So this is scar on the rotator cuff interval, and it's a finding that we can see in adhesive capsulitis or frozen shoulder syndrome. Though the frozen shoulder and adhesive capsulitis is really a clinical syndrome. You can't really make it on imaging findings, because these imaging findings don't necessarily correlate with the symptoms, and the syndrome are defined by the patient's symptoms, not the imaging findings. So I describe this as effacement of the rotator cuff interval fat, consistent with chronic capsulitis, and may be seen in the clinical syndrome of, quote, frozen shoulder or adhesive capsulitis. That's the way I like to put it, and I like to put frozen shoulder and adhesive capsulitis in quotes. But that's just the way I like to do it. And then often you'll also see thickening of the inferior capsule with this as well, and other areas. And I'll show some other examples later in talks. Okay, so that's rotator cuff interval scar. Let's see. Pablo, what do you think of this case?
Two actual views, one sagittal view. So it looks like there's post-op changes with some anchor devices anteriorly by the bicipital groove. Looks like in the one in the lesser and greater tuberosities on each side of the biceps. I don't see the biceps in the first image on the left, and then maybe there's a biceps between the two screws there in the middle image.
So what is
I don't know if it's scar. Well, probably repair of biceps tendon.
Repair. This is called tenodesis. So these are tenodesis grooves here, where if you have a symptomatic biceps, then one of the treatments is just to cut it and then tenodese it. Now, tenodesing is primarily done for cosmetic reasons. It doesn't really change the treatment at all. But if you don't, you end up with what's called a, quote, Popeye arm. But in reality, it's not Popeye at all. You can get a big mass in the upper arm on that side. But if you remember, Popeye had big forearms. But it's still called a Popeye arm. So anyway, and that can be disfiguring to females. Yes, John?
Usually it's the patient that decides the surgery, but folks over the age of 45 or thereabouts, they don't have it repaired.
Yeah.
And again, it depends on where the tendon winds up. If it's a Popeye shoulder, you really probably wouldn't want to mess with it, because it becomes a real big scar.
Yeah.
So this one here looks to me like the screws are in the wrong place, but it should be a little more distal. That becomes a tender area, right?
Yeah. And then what a lot of people are doing now is at the time they go in for a rotator, for a supraspinatus or a subscapularis tendon repair, if they see a lot of pathology in the biceps, sometimes arthroscopically they'll sever the biceps and then do a tenodesis of the biceps at the same time they do the rotator cuff repair. I see a lot of those in the last couple of years, and in which case they have to put it up high here because they do it arthroscopically with this same.
This too.
John, you're cutting out. We can't hear you.
It's like there are two devices.
Yeah, I know. I don't know. I don't quite remember exactly why.
The middle image.
Yeah. Yeah, I don't remember that. They might have done a supraspinatus repair as well. I don't remember.
The latest treatment for this is they have a special screw which is hollow, and they put sutures through it, and then they invaginate the tendon into the bicipital groove, the distal third.
Okay.
And then they suture the tendon, and that it's done. That's the most common procedure nowadays.
Okay. And here's just another example where they did an interference screw, but then the patient fell and actually ruptured the They were concerned about a rupture, but here on the MR scan, if we do the oblique sagittal, you can clearly see that the biceps tenodesis is still intact. So that they were concerned about rupture, but you can see the biceps tenodesis here nicely.
Yeah, once they heal, they heal, and it's a very stable situation.
Good. And then here we can see a loose body and the biceps tendon sheath here, which has been there a long time and has remodeled itself, but you can get loose bodies in around the tendon sheath. What do you think of this one?
All right, plain radiographs of the shoulder. Doesn't look all that bad. Here it looks like I can see the long head of the biceps, both intra-articular and extra-articular, and then inferiorly it looks like there's those loose bodies, or those.
And then you can see it here too.
Yeah,
it looks like little
bunch of round
synovial chondromatosis of the biceps tendon sheath. Okay.
Anterior shoulder pain after working out. Okay, I think maybe a bit of the same. I mean, there's an effusion, and there are small, hypointense structures. I don't know this. Sorry.
Rice bodies, and we can see here.
Yeah.
And here.
I guess they're small enough and homogeneous enough in size that they.
And that's ultrasound. And this was, again, synovial chondromatosis of the biceps tendon sheath. Good. So,
How the ultrasound?
I didn't. You can see them at the ultrasound as well. But I think they did the ultrasound first and then did the MR. Sahar, what do you think of this case?
You see a female with right arm paresis. So it looks that there is tear of the biceps tendon and there's fluid extending to the bicipital groove. So I think there are some fibers. Okay, there's large amount of fluid. It seems that it's within the tendon actually.
They call this an intratendinous ganglia, which is probably a form of chronic tear of the biceps tendon. Okay. All right. Thomas, what do you think of this case?
Chest pain, rule out pectoralis tear, and so that's the.
Okay, so here's the pectoralis muscle. The tendon is really kind of a sheet. It's usually a couple of centimeters long, but it's just a sheet, and it attaches to the humerus anterior to the biceps. In this location, if you remember the anatomy, we talked about, I think it was last time, right, where we talked about the latissimus dorsi and so forth. And then here is the PD fat set.
Right, so there's a lot of edema within and around the pectoralis muscle.
Okay, so how would you describe this, and what's the important finding on these studies?
So this would be a grade 2 strain of the muscle.
Yeah, you could say it, but it looks to me like there's hematoma formation within the muscle. So a lot of people would call this a grade 3 if you have hematoma. Or actually, grade 2. You're right. I'm sorry. You're right. I'm wrong. That's a grade 2. And then we can see here. And the thing is, since the tendon was intact and the tear is actually within the muscle, it's conservative treatment. It's not a non-surgical treatment, right? Okay.
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 The tendon is about an inch long and avulsed from the muscle, isn't it?
Yeah, here the tear is primarily within the muscle, but it involves the distal musculo-tendinous junction. But we can see it's. Well, let me see. Go here.
Right. Okay.
See that the tendon is here. The tendon is attaching to the muscle here. The tear is in through here. That's the distal part of the muscle, and there's the tendon coming off there. So the tear really here is intramuscular.
Yeah, It's kind of in between 2 and 3.
Okay, yep, I agree. That's right. And then, so it's important, these T1 axial images are really important because the status of the tendon in this location is really what's critically important. See, who did the last one? Was that Thomas? Okay.
So rule out pectoralis tear, an axial and a sagittal view. So I see medial to the humerus, it looks like there's some soft tissue thickening. Maybe the tendon, I think, is up there, curled up. So there's probably a complete tear.
So there's the long biceps tendon there. It should go over, the pectoralis tendon. It should go over the long biceps tendon and attach to the bone here. This has been a tear of the tendon at its attachment to the humerus, and then it's retracted medially. So this is a case where the tear is in the tendon, and so this would be a surgical case. And here we can see the tendon retracted down here away from the bone on the sagittal images. So that one went to surgery. Okay.
That's it. This is where you guys have to really try to put a marker on it as to where it is. I described it pretty well.
16-year-old American football player, chest wall pain after block. So in this one, it looks like the pec tendon attachment to the bone is intact, and it looks like the musculo-tendinous junction is torn.
Yeah. And here we can see it's retracted back, and there's fluid between the two. So this would be a really grade 3 musculo-tendinous junction. And then sometimes people say, well, is there enough tendon there to suture to? And unless it's off the bone, it's iffy in this particular case. And so there's debate. They ended up treating this one conservatively.
Okay, T1 and T2 coronals through the pecs. This is a weightlifter with recurrent right chest wall pain. So it looks like laterally there's right pectoralis muscle, like intrasubstance kind of. T1 and T2 is fat, yeah. Well,
it's fat there.
Yeah, but there's more than that too. Yeah, there's fluid too. Yeah, yeah. So it's I guess it's partially torn and maybe partly atrophied.
Well, it's basically, we can see that it's the patients have chronic tears, and this is an acute tear with hemorrhage on top of chronic tear, which is the fat deposition within the muscle and tendon here. So, and you can see the asymmetry between the two. This is the retracted muscle, the symptomatic one, and that's the normal muscle on the opposite side. And there we can see the fluid collection going in through there. That's where the muscle and tendon should be. And it's a new tear on top of chronic disease. And they elected not to operate on it.
He should take up another sport.
Yeah, right. Okay, last case for today. Sahar, what do you think of this?
64-year-old female with anterior shoulder pain. There's a lot of edema in the subscapular system. That there is tear of the subscapularis.
Okay, there's a big subscap. So there's a subscap tear, but what's this up here?
Okay, so there is fluid anteriorly slipped to the pectoralis. Is it pec minor?
And then here, sagittally, this thing right here. The pec minor, where does the pec minor go?
It goes to carcoid. This one.
And that was the pectoralis minor strain there. Good. Okay. All right, everyone. That's great. And then we will we'll start another topic tomorrow. Any questions about biceps in the area of the biceps?
And what topic are you going to talk about, John?